Hello, and welcome to tonight's VCU Health virtual seminar on prevention and treatment for women at high risk of breast cancer. My name is Blake Belden, and I'm a member of the marketing and communications team at VCU Massey Cancer Center. Tonight, we are joined by Patricia Bragg, a nurse practitioner, and Elizabeth Monast, a genetic counselor, as they explain how the high-risk breast clinic at Massey and VCU Health combines expert genetic risk assessment, state-of-the-art breast imaging, and access to comprehensive cancer prevention and treatment options for women at high risk of breast cancer. Before we begin, I would just like to make note that we'll hold any questions until the end, but please feel free to drop any questions you may have in the Facebook comments section throughout the event, and we'll address them during the Q&A portion at the end. Patricia Bragg is a nurse practitioner at Massey and VCU Health, where she specializes in breast health, both in patients who are at a high risk of breast cancer as well as benign patients. She graduated with a bachelor's degree from the VCU School of Nursing and has worked exclusively at VCU since. In addition, she also received her master's in nursing and is a certified family nurse practitioner. Elizabeth Monast is a licensed board-certified genetic counselor who provides counseling to patients in the familial cancer clinic and general pediatrics genetics clinic at Massey and VCU Health. She received her BS in biological sciences and psychology from Virginia Tech and her MS in genetic counseling from LIU Post. Elizabeth is also a clinical supervisor for the VCU Genetic Counseling Graduate Program. Thank you both for joining us this evening. Patty, I will now turn the show over to you.
Good evening, everyone. Thanks for joining us. I actually work through the Department of Surgical Oncology, and at this point, I am taking the majority of my patients are breast cancer patients. We added on this high-risk breast clinic a couple years ago, and it's been growing ever since. Next slide. So women are referred to our high-risk breast cancer, high-risk breast clinic for a number of reasons. And we get referrals from a lot of patients' primary cares that feel like they're at risk. Sometimes their OBGYNs are referring them. Sometimes I'm getting them from genetics, patients who have been referred there first. I also get referrals from medical oncology as well as the surgeons that I work with. So basically, I started out in surgical oncology taking care of a variety of cancer patients, and we've narrowed it down to breast cancer patients, and the high-risk breast clinic has been added as we've seen a need and as the guidelines continue to change and address that for women. Next slide. So what really makes someone high risk, and why would someone want to come to a high risk breast clinic? I think this was one of the questions that we had in advance. So women are referred to me who have a greater than 20% risk for breast cancer. And this is a lifetime risk for breast cancer. This can be based on genetic testing or other risk assessment. When folks come to my clinic, they initially are given either a tablet to complete some data points. We are now using a program called Cancer IQ, which has really made my job a lot easier. I used to have to enter a lot of the data by hand. That's the only way I knew how to do it. And a lot of times I would have to call patients later and let them know where their risk for breast cancer would fall. So today we have this Cancer IQ program that actually puts people into a sort of a database. And they are either sent a link to complete the data before their appointment, or sometimes we text it to them. We can send it to them in the portal. But overall, I think we're using the tablet in the clinic most often. And it just takes about 5 to 10 minutes to enter the data. And I'll go through some of those points as well. So that's really helpful. And I think it actually has generated a lot of interest in some other areas. Dr. Susan Hong has a survivorship clinic at VCU Massey, and she introduced the program. And I'm just trying to introduce it to as many folks as I can that are appropriate. So when we do the risk calculation on this Cancer IQ risk assessment tool, if women have a greater than 20% lifetime risk of breast cancer, they are eligible for certain additional screenings. They may also be eligible for genetic testing, or they might be eligible for a medication. Either way, if they're high risk, I offer to follow them on a regular basis and perform breast exams and talk to them about ways to reduce their risk. Next slide. So some of the risk factors that are included on this assessment that really factor in, I mean, all of them factor into the score, you know, the risk assessment. Age and race are factors that would affect the score. Patients who have had a history of lymphoma, usually women at an earlier age, are treated with chest irradiation. And this radiation of the chest really puts them at high risk for breast cancer. A lot of times there are no other ways around that. And so they're referred to our clinic to follow and offer them additional screening and guidance. So family history is definitely a risk factor that puts women at risk for breast cancer. It really depends on what degree of family. It could be first, second, or third degree relatives. It also depends on the ages that the family members are diagnosed with breast cancer and whether or not they've had breast cancer in both breasts. Breast density is determined on the mammogram, and there are basically 4 different levels of density. So extreme density is what puts women at risk for the most part. On the opposite of that would be entirely fatty breasts, which when we look at imaging, you can see right through the breast, and it's a lot easier to detect abnormalities. But you can imagine that women under 30 have, a lot of them have extremely dense breasts because their breasts are young and they're dense, and it's like a total whiteout when you look at the mammogram. And so women with high density or extreme density, as they call it, are at particular risk. Breast biopsies are another thing that may put people at risk for breast cancer. And that's not based on what the finding shows, it's based on actually doing the biopsies. Atypia is something that we see in pathology. Typically, women have had a biopsy, they've had a breast mammogram, or they've had an MRI that picked up an abnormality. And that abnormality is an indication for a biopsy. And the biopsy comes back with atypia, for instance. There's several types of atypia, and I'll go through that in a little bit. But basically, anyone with this atypia has a high-risk lesion, we consider it, that puts them at risk for an increased risk of a lifetime of breast cancer, lifetime risk. So also, when a woman starts her period, and also when she reaches menopause, so the shorter duration of, estrogen floating around in a woman's body kind of reduces her risk for breast cancer. Also, the age at first pregnancy. This is considered because, again, that is a period of a woman's life that they don't have a lot of estrogen floating around. So these are all factors that are considered and weighed heavily in the risk assessment tool. Next slide. So this is a little pie chart that just represents the breast cancers that we see. And I know that Elizabeth is going to go into this in a little more detail, but most of the cancers that we see are sporadic They're not associated with any particular genetic mutation. They just happen in women, and typically in an older age. Familial and hereditary cancers take up the rest, but the hereditary cancers are actually smaller than a lot of people think, given the wide range of folks that we see. So Elizabeth will speak to that a little more specifically. Next slide. Next. So I'm going to go over the particular risks for breast cancer and what we might recommend. So women that have a genetic mutation, now there are many mutations out there now, and they all have a degree of risk. Many people have heard about the BRCA genes, the BRCA 1 and 2, it's BRCA, which looks like breast cancer, but it's a BRCA mutation. And both of these genetic mutations put women at a particularly high risk for breast cancer, and men as well. A lot of times we will see a pattern of women that have had a family history of breast cancer in younger women, and that's a real alert for sending them for genetic testing. Also, women that have had more than one breast cancer or at a young age. So these are all reasons that I refer people to genetics. The lifetime risk, like I said before, this can be evaluated when they come, and it depends on a lot of those things that we talked about before. So we can start screening mammograms as early as age 30. Because like I said before, anytime before that, the breasts are extremely dense and it makes it really difficult to read. We can also start MRIs as early as 25 years of age. I have a couple of women that have started really early because they have heard or they were referred for a particular risk. The patients that have had breast cancer and also have extremely dense breasts are also, we feel, at a higher risk for breast cancer recurrence. Any age of breast cancer is certainly at risk for recurrence. But when we see women that were diagnosed at an earlier age with breast cancer, or they've had breast cancer with particularly dense breasts, that's also an indication for additional screening. Now, a lot of people ask about mammograms and, 2D, 3D. Most of the mammograms, I would say, are being done with 3D, I would imagine. I'd have to get specific statistics from our breast imaging colleagues, but for the most part, the insurances are all paying for the 3D imaging now. I think it's rarer that they're not. The MRIs would start for these patients that have a higher risk at whatever age they're diagnosed. And, the MRIs are not for the faint of heart, I say, because they're a long procedure, they're noisy, and they're not without risk. Patients have to have an IV put in, and they have to have it scheduled, and they're given a dose of gadolinium, which is the contrast medium that they use. It lasts a long time, and some women are not able to undergo MRIs for different reasons. Some people have allergies to the gadolinium contrast that they use. Next slide. Next slide, please. There we go. So back to the patients that have had some kind of lymphoma that required radiation of the chest, typically before the age of 30. We would start getting mammograms on them as early as 25 years of age, even though they have density, or 8 years after their therapy, whichever is later. MRIs, we would also start looking at starting those at about age 25. So back to the atypia. Patients that have had a biopsy that showed atypia. It could be either atypical ductal hyperplasia or atypical lobular hyperplasia or another type of atypia. These are all high-risk lesions. They're not breast cancer. They just put women at a higher risk, even though it's been surgically removed. They always follow up with me. The third is a little confusing. It's called lobular carcinoma in situ, which sounds like cancer. Lobular carcinoma sounds like cancer. So what we know is that this, in fact, is not a cancer. It is a high-risk lesion. It just has a really funky name that confuses people. So all three of these, the ADH, the ALH, and the LCIS, are all high-risk lesions that are found on biopsy and then further on excision. Those are all findings that would need to be surgically removed, which is a pretty simple procedure.
Hey, Patty, sorry to interrupt. I think you may have accidentally muted yourself.
Where did I leave off?
There you go. I think just since you started on the referrals page.
Thank you. And then
Yep.
I got logged out like I thought I would. Thank you, VCU. So referrals, let me just wrap this up. I refer women to Dr. Massey Ross to discuss risk. These are in the form of a pill a day for 5 years that patients can take. I also refer patients to genetics if that's indicated. I also let Dr. Ross have that conversation with patients. But if they are referred for risk reduction therapy, it's something that can reduce their risk by about 1/3 or a half, which is pretty significant. That's why we're making the referral. I also discuss breast awareness, which, in the form of teaching them how to do breast exams properly and effectively. We also discuss lifestyle modifications that patients can take a little more control over, such as diet and exercise, reducing or abstaining from alcohol, and not smoking are all ways to reduce risk for breast cancer that have been proven. So with that, before I get cut out again, I'll let Elizabeth take it from there. Thank you.
Thank you, Patty, for that very helpful presentation. I think it's always useful for patients to understand their more personalized risk scores based upon factors that you mentioned. So that was very helpful. Thank you. Again, my name is Elizabeth Monast. Thank you for having me this evening. And I'd like to go over a little bit more detail regarding hereditary breast cancer and how the genetic counseling process works. So, just a quick overview. We'll discuss some genetics components that are important for general understanding. We'll go through hereditary breast cancer. I'll discuss the genetic counseling process, and then we'll leave things off with the genetic testing for hereditary breast cancer. Next slide. Next slide. So I think it's helpful, first of all, to understand our DNA. DNA, or deoxyribonucleic acid, is essentially our instruction manual. It tells our cells what to do, when to do it, but most importantly, when not to do it. Our genes are made up of DNA, and we have approximately 20,000 genes in every single microscopic cell in our body. So pretty big instruction manual, pretty tiny amount of space. And the genes control how every cell functions, including how quickly it should grow, when it should divide, and how long it lives. And I think it's important to know that we all have BRCA1 and BRCA2 genes, or BRCA1 and BRCA2 genes. Men and women, we each have 2 copies. And in fact, those are good genes to have. They are tumor suppressor genes, and they're responsible for normal cell growth and development. And it's when we have a mutation in one of those genes that we run into problems. And I'll discuss that here in just a moment. Next slide, please. So this is just kind of a schematic. You'll see here the cell, and inside the cell is the nucleus, and that contains our chromosomes. And the chromosomes are how our DNA is packaged, because DNA is extraordinarily long. And so in order to keep it condensed and organized so that the cell can access it as it needs to for normal day-to-day functions, the genes are packaged onto chromosomes. And we get half of our chromosomes from mom in the egg, and we get half of our chromosomes from dad in the sperm. And subsequently, we get half of our genetic makeup from mom and half of it from dad. So we get essentially 2 copies of every single gene. We get a version from our mother, and we get a version from our father. Next slide. So mutations are the term that we use for alterations or genetic change that has abnormal or not in the typical arrangement that we would like for it to occur in. Certain mutations can have been directly linked to an increased breast cancer risk. And as Patty mentioned before, there are thousands of mutations that can exist in all of those genes that I just mentioned. And additionally, there are genes that are being discovered and researched even to this current moment, and we're still trying to figure out just exactly how they confer risk and to what degree that risk is elevated. The important thing to understand about mutations in cancer is that mutations can be either, one, inherited, like we discussed with hereditary breast cancer, and they exist in an individual's germline, which means they received that mutation when either mom's egg fertilized or was fertilized by dad's sperm, or vice versa. Now, generally, though, in the case of cancer, we're talking about somatic mutations, which are mutations that occur over the course of a person's lifetime and can be the result of, environmental exposures or other factors, such as smoking, alcohol use, etc. Next slide, please. So this is just kind of a little picture demonstrating the differences between somatic mutations and germline mutations. Again, with somatic mutations, they can occur in any tissue in the body. So when you think about breast cancer, generally speaking, we're talking about a mutation that occurred within a cell inside the breast tissue. And then that mutation led to abnormal cell growth. Damaged cell, so to speak, made copies of its damaged self, and that ultimately led to that breast tumor that was detected either on a mammogram or self breast exams or others modalities. Now, with germline mutations, though, you don't necessarily have any idea that you're carrying that mutation unless you have genetic testing. This germline mutation is present in either the egg of a female or the sperm of the male. And depending upon which version of that mutated gene is passed on, it will be then passed down to children with a 50% chance with each pregnancy. And these are the types of mutations that we are doing the DNA analysis for when we talk about hereditary cancer syndromes. Next slide, please. So an important take home is that all breast cancer, all cancer is genetic in origin, meaning that a mutation has occurred that resulted in abnormal cell growth. But most breast cancer is not hereditary, meaning that the mutation that's led to the cancer development was in fact in that person's germline, or what they inherited at the point of conception. Next slide. Next slide. So just as Patty mentioned, here's a little distribution, and she made a very good point. And I think this is one thing that patients are often surprised to learn, is that only about 5 to 10% of all breast cancer that's diagnosed is hereditary to our knowledge, which means we can identify a mutation when we do this germline testing. So 70% of breast cancer is sporadic, meaning unfortunately it just happens by chance. And there are certainly things that can increase or decrease risk for developing breast cancer in one's lifetime. And about 20% of breast cancer is familial. So often we'll see patients, well, I have such a strong family history of breast cancer, it must be inherited. Well, not necessarily. With familial breast cancer, just like things like diabetes or heart disease or Alzheimer's can run in families, cancer can do the same thing. And that's because as families, we tend to have shared environmental risk factors, lifestyles, health behaviors, and then additionally, we have common genetic makeup. And it's a combination of genetics plus those other factors that can put families at higher or lower risk for diseases, cancer included. It's not because the cancer is the result of a gene mutation that's being passed down from parent to child. Next slide. So I think that this is kind of helpful to keep in mind when we talk about hereditary breast cancer. I'll go into this in a little more detail in the next slides coming up. One of the red flags we look for in a clinical setting are early onset diagnoses. And that can be explained by this theory called the Twohit hypothesis. So with sporadic cancer, let's just say, for example, we're talking about BRCA1, okay? As I mentioned, we all have BRCA1 mutations. So I have a BRCA1 gene version that I got from my mom in her egg, and a BRCA1 gene version that I got from my dad in his sperm. So if we look at sporadic cancer up top, you have two working versions of a cancer gene, one from mom and one from dad. And over the course of your lifetime, say you pick up the not so great habit of smoking cigarettes, that is proven to be a cancer risk factor. Let's say that smoking results in a mutation in one of your cancer genes. That's okay. You still have that other copy that's making the protein, doing the things, providing the instruction that your cell needs for normal growth and development. But let's just say you continue down the path of smoking, or maybe there's, again, not to pick on people, but maybe a heavy tanning bed use or some other type of risk factor that results in another injury or another mutation. A second hit is what we call that. And now you have a mutation in both of those cancer gene versions, one from mom and one from dad. Now neither one of them are working. The cell has essentially lost that regulatory ability, or has lost that function of the gene. And now the cells don't have the control that they need. They make copies of their damaged self, and we have a cancer or a tumor. Now with hereditary cancer, you're down one from the start. Unfortunately, you've inherited a mutation from one of your two parents, and you can live your whole life in this state and never go on to cancer, having one broken version and one working version. But if you do go on to acquire a second mutation, that can ultimately lead to the same outcome as we mentioned before, where we've knocked out the regulation or the normal gene function, and the tumor can take hold, or essentially the cells are growing abnormally. Okay, next slide, please. So just to hit back on that again, not everyone with an altered gene or a mutation in a cancer gene develops cancer. There's a lot that we don't understand about modifier genes and how cells respond to DNA damage and how they repair it. And there also, as Patty mentioned so nicely in her first slide series, was that there are other risk factors that are involved in cancer development. And those things can be hormonal, reproductive, and they certainly can impact whether or not a person who has a germline mutation actually does go on to develop a malignancy. Next slide, please. So just to briefly hit on the inheritance pattern, I know that there's a question about this is at the beginning in our subset of questions that were released. It's like, okay, well, if I have a mother or if I have a sister with a BRCA mutation, should I be tested as well? And the answer is yes. And the reason behind that is that these gene mutations move through families in a pattern called autosomal dominant inheritance, which is basically just fancy genetic lingo for saying, if you have a carrier parent, there's a 50% chance you are going to be a carrier yourself and also have that elevated cancer risk. So, it's an independent event every time a pregnancy is conceived. So if there's a carrier parent, there's a 50% chance they'll pass that mutation on. There's a 50% chance they will not. And if you are not a carrier, you cannot pass on that mutation. You cannot pass on something you don't carry yourself. So I have seen cases clinically where we've identified a carrier parent, and then we go on to test children. And luckily, because it really is, essentially a coin toss, all of the children have tested negative. There have been, unfortunately, other scenarios where everyone has tested positive, or there's been a combination of positive and negative individuals in a sibling relationship, and that can certainly raise its own complications at times. Next slide, please. So just to recap the red flags that we look for, kind of thinking about that Twohit theory, early ages at diagnosis are a red flag. So we look for breast cancer diagnoses occurring prior to age 50. And then multiple relatives on the same side of a family with breast cancer. So it's important that we take into account a single family lineage at a time. So mom's side or dad's side. Other red flags include bilateral disease, so breast cancer in both breasts, triple negative breast cancer, which is estrogen, progesterone, and HER2 new negative breast cancer. And then, as I mentioned, that pattern of autosomal dominant inheritance, so we see multiple generations affected. And then additionally, we can see certain features that are suggestive of one particular cancer syndrome versus another. And those can include things like rare tumor types, including male breast cancer, pancreatic cancer, ovarian cancer. Or we can see a constellation of cancers in a particular individual or a family that we know are consistent with a specific syndrome. So, for example, BRCA1 and BRCA2 mutations confer an increased risk for cancers of the breast, cancers of the ovaries, cancers of the pancreas, prostate. And we can usually, with some clinical accuracy, determine or come up with a differential when we're looking at some of these families. And then lastly, another risk factor, because of a phenomenon called the founder effect, Ashkenazi Jewish heritage, also is something that we evaluate or ask about in our sessions to see if there may be a greater probability that the cancers in a family are the result of a germline mutation. Next slide, please. All right, so the genetic counseling process is a little, well, I'm maybe a little biased, but it's very important to helping patients understand not only their personal risk, but also help them adapt to understanding this risk, as well as addressing any concerns that they may have from a psychological or emotional perspective, and also helping them navigate some of the familial implications of the genetic disease, in this case, hereditary breast cancer. Next slide. So it may be a little bit of a misnomer. I know when genetic counseling was in its infancy, there was kind of a question about whether or not genetic counseling, like I don't need my genes to be counseled or therapy for my genes or whatnot. And there we do, of course, in our field address some of the psychosocial concerns that may come with a complex diagnosis or family history. But it is not a therapy session in the traditional sense that you might receive psychotherapy. Next slide. So overall, we're hoping that patients are able to integrate the information that we give them and making kind of informed decisions that are respectful of kind of their values as well as their family's goals and hopes. We want them to be able to make informed choices where they feel comfortable not only with the information, but their ability to interpret that information. And then also feel like they are able to adapt not only themselves personally, but perhaps help other family members adapt to the risk that might be involved with this particular mutation. So overall, it's a lot of, kind of prevention resources, research resources, and helping them understand the disease mechanisms and what they can do to address that. Next slide. So with genetic testing, I'll just let this little slide pop up here for itself. But I can read it out for those of you who might like that. As genetic counselors, sometimes we're in a position where we deliver awkward news or difficult news. But in this case, the genetic counselor is meeting with the patient, and the patient asks, "Did my genetic test come back?" And the genetic counselor says, "Yes, sit down." And the patient says, "Is it bad news? What are my risk factors?" "We can't be sure about this, but we've analyzed genes on several of your chromosomes, and it's hard to avoid the conclusion. At some point, your parents had sex." "Oh God," says the patient. "Stay calm. It's possible it was just once." Patient says, "Oh my gosh, I need to be alone." So this is just a little bit of levity. Certainly, there are circumstances that are not going to be quite so silly, but it's important to know that here that genetic counselors are involved in the process of delivering information and helping patients cope with that. Next slide, please. So with genetic testing, the COVID-19 pandemic has kind of forced the hand of delivering a little bit of the genetic testing realm. Genetic testing, for the most part, can be performed on various different sample types, and that's going to be patient specific, and in some cases will be determined by a patient's clinical status. So often the samples are blood or they're buccal or saliva. But in cases where we're dealing with a patient who may have had some really intensive chemotherapy, though that's less of an issue than it had been, or patients who have had a bone marrow transplant, or patients who have had or have an active heme malignancy or blood cancer, we do need to take steps to ensure that we're looking at the DNA of the individual's germline, not the DNA or the mutations that are the result of either a blood cancer, for example, and also make sure that we're looking at a patient's genetic makeup that is theirs, not a donor's, in the event that they may have had a bone marrow transplant. So that can all be coordinated and determined by the genetic counselor to ensure that the testing sample is accurate and will give accurate results. Testing kits can be shipped to patients at home now for collection at home. And most insurance companies are covering the cost of this genetic testing, particularly if established criteria are being met. There are insurance providers that have very specific criteria amongst their own plans that they follow. But typically, if a patient meets NCCN guidelines or the National Comprehensive Cancer Network guidelines for genetic testing, insurance companies are covering the cost. But the testing has become quite a bit more cost effective, or a little more approachable from a financial perspective. And most patients do now have the option to pay for the testing out of their own pocket without insurance, and the average cost for that is about $250. Test results are usually, on average, about 2 to 3 weeks to come back, and that's all dependent on the specific test that was ordered in the lab that's doing the testing. But there can be cases where we need to have that testing ordered stat for patients who may need surgical decision making. And if it's a blood sample, the blood's collected in the office and then that's shipped out overnight, we can sometimes get test results back in as quick as 5 days. Next slide. So Patty kind of was hitting on this in her lecture as well, about how we work with patients to clarify their personal risk levels and how to address that. And the benefits of genetic counseling are to kind of add another layer of personalization to a particular individual's cancer risk management plan. And we can give them strategies like more frequent imaging or screening protocols. We can recommend things like prophylactic surgery, certain medications like tamoxifen, or adjustments to lifestyle, including, healthy diet, managing body weight, as well as maybe cutting out hormone replacement therapy if that's been prescribed, or limiting alcohol use or smoking cessation. Then for those patients who have been diagnosed with breast cancer, we talk about options for treatment, including surgical planning, as well as certain medications that might be helpful because of their germline mutation carrier status. For example, BRCA1 and BRCA2 mutations, there are a class of drugs called PARP inhibitors that are particularly efficacious in that patient population. Next slide. So another important part of the genetic counseling process is to ensure that patients have informed consent. And we go through all the considerations that they may want to make prior to submitting a sample and getting test results back. So even if we do genetic testing, it's important to know that only about 5 to 10% of breast cancer is the result of a gene mutation that's passed down from parent to child or hereditary. So there's that continued risk for sporadic cancer. So it's not a, kind of get out of screening free card if you have a negative test result. And it may not rule out hereditary risk. That's the other important thing. For our typical breast cancer panel size, if we were to do a comprehensive breast panel, we're looking at a ballpark between like 18 to 28 genes that have been associated with hereditary breast cancer. If you recall, there are 20,000 genes that exist in every single cell. So there's a lot that we don't know. And just because testing at this point in time may not identify a mutation, it doesn't eliminate the possibility that there could be a mutation. It's just in a gene we haven't discovered yet or cannot test you for. A step further from that is what has happened is our ability to test has gotten a little farther ahead of our ability to interpret. And there are some genes that are now on clinically available panels that may not have the greatest medical management guidelines, or may not have risk levels or risk management protocols that are very well established, or there's a lot of consensus on. So what that can often mean is that if we have a test result that comes back positive, we may just be able to tell a patient, well, this mutation or this gene has been linked with an increased risk for breast cancer, but I don't have a precise, number I can prescribe or assign that risk level for. And additionally, I may not be able to give suggestions on how best to manage that risk. And then, of course, with these gene mutations, for the most part, we're talking about adult onset risk. So testing of minors is not encouraged. We generally would like for patients to have the testing discussion for hereditary breast cancer after the age of 18, once they can make kind of an independent, informed decision as adults. And then finally, I do like to just kind of briefly hit on genetic discrimination. There are now federal laws, and there's been a federal law called GINA, or the Genetic Information Non-Discrimination Act, that has been in place since 2008. And what GINA says is it's illegal for health insurers to take a positive genetic test result and use it against patients as a pre-existing condition. So that does protect, to a certain degree, health insurance, but the GINA law does not apply to families who may have their health insurance through a private employer with 15 or fewer employees. Also doesn't apply to the military. And GINA does not extend protections for things like life insurance, long-term care insurance, and long-term disability insurance. So those are discussions that are important to have on the front end before patients elect to have testing. And then certainly, as I mentioned in the one picture explaining how gene mutations are inherited, there are situations where we will have a carrier parent, and then we will have children that elect to have testing done. And that can certainly be a complex situation for families to navigate. It can be hard for some individuals to learn that they were positive or negative. There's that, always a discussion that we'll have regarding anxiety or survivor guilt, and other implications that a positive or a negative test result can have for a patient. Next slide. So just in conclusion, as I mentioned, all cancer is genetic, but most cancer is not inherited. As Patty discussed with her slides, there are lots of risk factors for cancer, some of which are identified just by doing a mammogram and learning whether or not a patient has breast tissue that's dense or fatty. And then the likelihood of someone having an inherited risk for cancer is something that's determined by a patient's personal history as well as their family history. And genetic counselors work with patients to help them and their families, as well as their providers, if necessary, understand the test results and how to make informed decisions regarding those test results. And ultimately, the test results can impact medical management and improve patient outcomes as long as there's been a discussion that is comprehensive and allows for them to make, informed decisions. So that is all I have. Thank you.
Well, thank you both for that really helpful presentation. We'll now open it up to some questions. I'll go ahead and read a few that were submitted beforehand. Elizabeth, I think you did a good job of covering a few of the genetic risk questions that were already asked. We have, what are some breast changes that should always be evaluated and discussed with a healthcare provider?
I'll take that one. So any woman that comes in for a breast evaluation, I always ask them about any skin changes on the breast, whether or not they've had any redness or rashes, any lumps, anything abnormal. That's why we encourage breast self-exams. We call it breast awareness now. No more often than once a month. Because women were finding things when they were examining their breast too often that necessitated imaging for them. And actually, some harm was caused by doing that more often. The nipples are a particular area to pay attention to. If there have been any changes in the nipple, in the skin of the nipple, or certainly if there's been any discharge from the nipple. That doesn't always mean that you have cancer, but it's worth evaluating and looking into.
Okay. I know you both have touched on this a bunch, but if you could, maybe each of you kind of say, how is the high-risk program at Massey different from other breast health clinics?
Well, we pay particular attention to their risk for breast cancer, and we evaluate them to see if they're eligible for additional screening or surveillance, or certainly if they're eligible for risk reduction therapy or genetics.
Yeah, and I'd like to echo exactly what Patty said. I think the nice thing about having these high-risk breast clinics is that it provides patients with a kind of a one-stop shop, and they can go in and they can meet with providers who have all of their different specialties as it pertains to a very specific disease of the breast, whether that be cancer or some other type of problem, or even if it's not truly yet a malignant process, maybe it's something that we're just monitoring them with either one, the hopes of preventing it, or two, catching it early in the event that maybe they're at elevated risk because of a mutation that they carry or other risk factors. So I think the multidisciplinary approach is a really important one, and one that Massey does offer.
Okay. How can breast biopsies increase the risk of breast cancer?
So I mentioned breast biopsies, but what I should have said was multiple breast biopsies. And it's not so much the actual biopsy that causes the risk. It's the reason that they were having the biopsy. It's what the tissue looked like behind it that can put them at risk. And so, the breast changes that are observed on mammogram are more of, what we're talking about. Also, the increased density on breast imaging. I hope that's helpful.
If you've already had breast cancer, will genetic testing help predict the risk of recurrence?
Yeah, and that's a great question, and I think it's a little twofold. It really depends upon the type of genetic testing that's being ordered. So, when we talk about genetic testing in breast cancer, it's important to differentiate, I think, between germline genetic testing as well as the genetic testing that's actually done on the breast tumor itself. So there are certain tests that I can't speak to specifically, but things like oncotype, those are tests that are more of a profile of the tumor, and that can give the oncologist a sense for how aggressive that particular breast tumor is behaving and what the chances are of it recurring if certain things are not done, including like chemotherapy. But in the realm of hereditary breast cancer, yes, there are certain genes that we know of that if a woman has had breast cancer once, her chance for developing a second breast cancer or a bilateral breast cancer, or breast cancer on the opposite breast, is elevated. And in those particular circumstances, we talk about genetic testing often before surgical decision making. And what happens in those cases is if we have a patient who tested positive for a BRCA mutation, has a current breast cancer diagnosis, perhaps her tumor size is small with the current diagnosis, but we know her chance for getting breast cancer again is great. So rather than maybe doing like a breast conserving surgery, which would be appropriate if she weren't a mutation carrier, doctors would talk to her perhaps about prophylactic mastectomy instead, because we know the chance for her getting a second cancer is great.
Okay, great. I think that's all we have as far as questions. So, Patty and Elizabeth, thank you so much. It was a pleasure having you join us for this important discussion. For more information about high-risk breast cancer, you can follow at VCU Massey Cancer Center on Facebook or visit Massey Cancer Center at masseycancercenter.org. Once again, thank you both. And to anyone who joined us this evening, have a great night.